My name is Roxanne Chabot from RBC Consultants. Welcome to another International Dermatology Education Foundation Educational Series webinar. This evening, we're going to be talking about a new treatment for adults with severe alopecia areata, LEQSELVI. Our moderator this evening is Dr. Danielle Butler, who is Associate Professor, Division of Dermatology, and Assistant Dean of Student Affairs, as well as Director of Inflammatory and Aging Skin Research Program at the University of Arizona College of Medicine in Tucson, Arizona. Our speaker this evening is Dr. Meena Singh, who is Medical Director, Skin and Hair Center at Overland Park in Kansas. We'd like to thank our supporter, Sun Pharma, for making this educational event possible. Before we begin, a couple of logistic tips. If you're having issues hearing the webinar, you can listen to the presentation using your telephone. Just select phone call in the audio pane and the dial-in information will be displayed. If you're having technical issues, please submit your questions in the question chat pane on the right-hand side of your screen. At the end of this webinar, a survey will pop up in your screen as well as be sent to you 1 to 2 days later. We'd greatly appreciate it if you would fill it in and send it back to us. Within 1 to 2 days of the webinar, a certificate of attendance will also be sent to you. Again, if you'd like to submit questions to our faculty, please submit your questions in the question chat pane on the right-hand side of your screen. And now, without further ado, I will pass the floor virtually to Dr. Butler.
Thanks so much, Roxanne. I'm excited to be here to introduce our speaker and talk a little bit about our group here. So if we could go to the next slide. So as many of you probably know, this is a presentation of the International Dermatology Education Foundation. So this is a nonprofit which is transformative for the educational mission of all of dermatology. And this is a webinar series that continues to really populate great educators across all countries to help us understand more about dermatology. And there's so many topics that we touch on here, and we love engagement with the audience. So please continue to tune in for all these wonderful speakers. You can follow us on any of the socials, Instagram, LinkedIn, Facebook, and engage with us and register for any of the upcoming webinars. So without further ado, I know why all of you are here. You want to talk about full speed ahead, a new treatment for adults with severe alopecia areata, LEQSELVI. So without further ado, I want to introduce Meena Singh. She's world famous. You've seen her everywhere. We're excited to hear from you, Meena. So I'll let you take over from here. Thanks so much.
Thank you so much. Thank you for the introduction. Happy New Year, everyone. So yes, we'll be discussing LEQSELVI. Let me use, okay, and you know what? I gotta shrink this side panel so I can actually see. Let's pull it over there. Okay. So yes, we're discussing LEQSELVI. It's a treatment for severe alopecia areata, and it can deliver fast results. So we'll talk about that and get into all of it. Okay, and just so we're all clear, this is a promotional program. I am being sponsored by Sun Pharma, and we're going to stay on label as well with our discussion of LEQSELVI. Okay, so LEQSELVI is a JAK inhibitor. That is its mechanism of action, and it's indicated for the treatment of adults at this point with severe alopecia areata. We do not recommend using LEQSELVI with other biologics. So this is something that, you know, I have a patient right now that has psoriasis, vitiligo, and alopecia areata. Just saw him today, actually. And so we had to have those discussions, you know, what do we want to focus on? What is most important? What is most severe? Because it is not recommended to combine at this time. We have other patients that have atopic dermatitis and may be on other biologics. And so you might have to decide, you know, to switch just to LEQSELVI or to other JAK inhibitor versus other biologics. So that's important to know that at this time, you know, I wouldn't combine. It's not recommended. And then LEQSELVI is contraindicated in patients who are poor CYP2C9 metabolism, and we're going to get all into that. Okay, and just like all the other JAK inhibitors, LEQSELVI does have box warning. So the box warning is just like all the other ones: serious infections, mortality, malignancy, MACE, and thrombosis. So specifically with LEQSELVI, malignancies have been seen. For the increased mortality, that was mainly seen, you know, with the different JAK inhibitor versus TNF blockers. The serious infections can happen with LEQSELVI as well. And we'll talk about screening for tuberculosis. And they mentioned that I am here in Kansas. And a couple years ago, actually, we had this outbreak with tuberculosis. And actually, prior to them calling it this outbreak, I was, I'm one dermatologist and I only check or screen for TB for biologic medications to start those medications. And I diagnosed 4 people with latent TB in 1 year just for what I was doing. So very, very important that we are screening for TB. And in those patients, actually, all of them were able to start whatever biologic I was trying to put them on. I just had to get clearance from their primary care, and they're doing serial chest x-rays. And then some of them did go ahead and see infectious disease. So if you do have a patient that does screen positive for latent TB, that's something that it can be possible to go ahead and stay on or start the medication. Okay. And then also thrombosis did occur in patients that were treated with LEQSELVI, but we're going to get more into that when we go over the adverse events. Let me go back. Okay, and then I'm going to kind of skip through this part with the CYP2C9 because we'll talk about this in more detail, because we are going to have to screen for poor metabolizers of CYP2C9 with LEQSELVI. So that is like a whole thing. We're going to talk about it. But if the patient is found to be a poor metabolizer, and interestingly, it's only about 1 to 2% of the population, then it would be contraindicated. As far as immunizations, so if you screen a patient and you know that they're at high risk for shingles, or they want to immunize for shingles or other potential live vaccinations, you would want to discontinue the treatment or pause the treatment for a couple weeks before they get the immunization, or consider getting the immunization prior to initiating. Okay, and we'll get into the adverse reactions, so we'll skip through this. Okay, so overall with alopecia areata, we see a ton of this. It is an autoimmune disease. It is considered chronic. So unfortunately, if we grow and get all the hair back and get full regrowth, it still has the potential to lose the regrowth in the future. And so, with LEQSELVI in particular, this is considered to be a chronic medication. If we start it and we get a full hair of regrowth and the patient's very happy, we do need to inform our patients that they would need to sustain that medication in order to have those results long term. So with alopecia areata, we know it's a non-scarring hair loss. It can affect the scalp, eyebrows, eyelashes, facial hair. It can affect body hair. And it's really interesting, in our male patients, sometimes, and I'm sure some of you have patients like this, the scalp hair loss is not as frustrating for those patients. It is often the eyebrow, eyelash, and beard hair. And I'm not sure why, but I think with female patients, often we can mask it a little better. We can do our eyebrows, we can do our eyelashes. With men, it's not considered necessarily socially acceptable to fill in their eyebrows and wear fake eyelashes. So often I've had patients before we had JAK inhibitors who wanted me to do treatments just for their eyebrows or eyelashes because that's what bothered them the most. So that's always interesting. And of course, we know that there are varying presentations. There's the multifocal patch stage, there's the ophiasis stage in the back. And often, I'm sure you guys have found this as well, in ophiasis pattern, it is harder to treat. And I've had patients who start off ophiasis and then unfortunately transition into totalis. And interestingly, the totalis, the remaining areas that were not part of the ophiacis pattern will regrow faster, and the ophiacis pattern will take the longest to regrow. Okay, it happens equally in men and women, impacts all racial ethnic groups, and it affects about 2% of all individuals in the United States, and that is about 700,000 individuals in the United States. So it is impactful, and about 300,000 of them do go on to have severe alopecia areata, meaning greater than 50% hair loss. So it's really important to note that alopecia areata, as you all know, it really disrupts our patients' lives. It's not just hair loss. It really changes how they're perceived by the world. 1 month they look a certain way. The next month they can look like a completely different person. Often, even when people don't have totalis and they have the patch stage, they're kind of chasing the patches where, they're wearing one hairstyle to cover up one patch and then the next hairstyle to cover up the other. So it can be really frustrating. I've had patients who unfortunately, it affected them so much that their children actually never knew that they had the hair loss because they were afraid to show their kids. They were concerned that they would think that they were sick from cancer. And so it's something where they're having, you know, internalized trauma, internalized shame from it. It's just really challenging. So this slide is kind of talking about the same thing that we already kind of discussed. You know, eyebrows, eyelashes, they are actually important. They are functional. They decrease sweat traveling into the eye. And nail changes, if you have the trachonicia from alopecia areata, that can cause brittleness and pain with the nails if they have fractured nails. And like we said, there is a psychosocial impact. It can really lead to withdrawal, anxiety, and even if your hair is growing back, you may be anxious about when the next shoe is going to drop. When is the hair going to fall out again? You know, you're just anxious about what's going to happen next because it's so unpredictable. And then there is a financial impact. Our visits may not be cheap. Our copays may not be cheap. Just the coverage may not be cheap. And so it's something that really affects our patients beyond just the fact that they don't have hair on their head. Okay, so just, you know, it's really important to note, just while we're canceling our patients, if the episode duration has been greater than 4 years, the likelihood of an adequate response, meaning that they get their full head of hair back or they get even some hair back if they have totalis, is going to be lower. So that's something we really need to talk to our patients about so that we can kind of tend to their expectations and what they're anticipating the response to be. And then if they have a duration of disease greater than 10 years, they may have a reduced treatment response. So what that means is, let's say we have a pediatric patient that's had a patch here or there since they were 10 and now they're 25, they may not respond as well as someone who develops a disease state just a couple years prior to them. So just things that you can kind of counsel your patients about. And then this is an interesting slide. Okay, so they surveyed patients versus providers, and they found that 83% versus 72% of providers, so 83% of patients preferred that the JAK inhibitor, not just adequate response, but the speed to response was important. And I think it's really interesting because that makes sense. As providers, we're not the ones living with the hair loss, right? We're looking for efficacy. If they get efficacy, awesome. The speed is not something that we're always focused on because we just want them to get their hair back over time. And that is our natural expectation. I think we have more measured expectations. With patients, they want their hair back now. So that makes sense. And so we need to be cognizant of that as caregivers. So this is really interesting too. So, you know, LEQSELVI is the third FDA-approved alopecia areata medication. You know, does it make sense to keep putting out these medications? You know, why do we need another JAK inhibitor? So they found that up to 30% of patients on JAK inhibitors did not respond to therapy as of 2019, and that if they did not have adequate response to one JAK inhibitor, that did not preclude success when you switch to another. So that's just really interesting. I would not use failure of one JAK inhibitor to decrease my likelihood to put them on another one. So it's just really interesting that they, you know, looked at that because it is something that people ask about. You know, I've already tried this. I've already tried this. I've already failed a JAK inhibitor. Why would I try another one? And so this is something that we can tell our patients. Okay, so let's talk about LEQSELVI's efficacy. Okay, so LEQSELVI so the dosing is 8 milligrams BID. So that's what we're going to be mainly focused on, but they did look at other dosage with the Thrive AA1, Thrive AA2 clinical trials. And so we are going to be focused on the 8 milligram BID because that's the FDA approved dose, but they did look at other doses. And so the inclusion criteria was 18 and up, 18 to 65. They had to have a SALT score greater than 50, so considered severe alopecia areata, and they could not have had alopecia areata, that particular episode, more than 10 years, and the episode had to last at least 6 months. The primary endpoint was to achieve a SALT score less than 20 by week 24, and then we'll talk about some of the secondary endpoints as we get through the slides. Okay, so just a reminder, SALT score, I always have to remind myself, the higher the SALT score, the more the hair loss. So SALT 100 means complete hair loss, SALT 0 means no hair loss. Okay, and so let's talk about the AA scale real quick, because in my practice, SALT score is part of the evaluation for when I may consider starting a systemic like a JAK inhibitor, but I tend to use more of a kind of a cursory AA scale. So how much scalp hair loss do they have, but also what else is going on with them? Do they have rapid hair loss? And so that is someone that may have only 20 to 30% scalp hair loss, meaning they have most of their hair is covered by, most of the scalp is covered by hair, but the hair is coming out in clumps. They have really active shedding hair loss. That's going to push me up when it comes to severity for that patient because of the activity of the hair loss. Have I been treating them for more than 6 months, maybe doing intralesional steroids, topicals, oral minoxidil, etc.? And yes, the patches that we're treating, excellent, they're getting some regrowth, but they're getting new patches. Or they're getting some regrowth, but it's not fully regrown. And so after 6 months is my cutoff as well. That's when I'm going to consider a systemic medication. If they have eyebrow eyelash loss, that is a patient that is going to be moved up very quickly for my consideration for oral medications such as LEQSELVI. And that is because I've been treating alopecia areata for such a long time now. I have not found a good medication or in any way to treat eyebrows and eyelashes adequately until now. So in the past, I've been, tormenting patients with intralesional steroids, maybe PRP, topicals. I have not seen the same efficacy as I have with oral JAK inhibitors. So that's going to push me up in severity. And then how is it affecting the patient? Are they making eye contact with me? Are they talking? Are they crying? How is it affecting them? If it's something where they literally can't manage their day-to-day because of their hair loss, that's going to put me up in severity. And then, the percentage of scalp coverage is going to be important, but those factors are going to play a role as well. And, when you're prescribing LEQSELVI, they may ask about these things. So it may be things that you would want to put in your chart anyway. So this is something that you may want to just note for those patients anyhow. Okay, so let's look at the population that was studied with LEQSELVI. And it's just these baseline patients were severe. You can see the average duration of current episode was 4 years. And we just talked about how with 4 years, the likelihood of adequate response is going to be lower. So these are patients that have had a long duration of their episode. Most of them have near complete hair loss. So over 60% of them had near complete hair loss. So that's 95% to 100% scalp loss. And then the total scalp loss in these patients, baseline was 87%. So these are patients that I think are very, very representative of our hardest patients to treat. And so I think it's really important to note that when we look at, the efficacy of these particular patients. So our hardest patients to treat, how effective is LEQSELVI? So let's get into that. Okay, so these results are pretty interesting. You can see at 8 weeks, LEQSELVI already met statistical significance. So by 8 weeks, there were only about 3% of patients that achieved a SALT score of less than 20, but that was considered to be statistically significant. And then by the end of 24 weeks, it was over 30% of patients. And again, this is the 8 milligram BID, and there were, again, other doses that were looked at, but the 8 milligram BID is what is being shown here. And this is just a representative patient in the trial. So you can see this patient has near complete hair loss. Her baseline SALT score is 90. By the end of the 24 weeks, SALT score 0, full head of hair, and she almost looks like a different person. So this is definitely what you considered a success story. So this is someone that is very, very happy. And again, unfortunately, this is not someone that we should be telling this patient that they should see LEQSELVI as a long-term chronic medication in order to sustain their results. So we do need to note that with patients like this. And this was really interesting. This is one of the patients that had a baseline SALT score of over 50. So, right at 50% hair loss. And by week 8, did see a SALT score less than 20. I don't think these pictures are the best pictures to illustrate the fast responders, but you can see that, the hairs are coming in white. And so the pictures aren't as striking, but this is someone that did meet that specific endpoint at week 8. Okay, and I love these slides because the questions are, okay, but how many patients are partial responders and when are they responding? Because, with our patients, it's all about what can we anticipate? Giving our patients a little bit of hope. It can be very, very frustrating to be on a medication for 9 to 12 months and not see any regrowth potentially, right? So this is showing partial response. So by Week 24, around 50% of patients did achieve a SALT score of 50. And so if we go back to that baseline statistics, if you recall, it was mean 87% scalp hair loss in the baseline statistics. So about 50% of those patients were able to go down to a SALT of 50, so 50% coverage by week 24. And so that's not the primary endpoint, but it's nice to see because this is our real life, right? This is what happens in our clinic. We're able to say, okay, not full head of hair yet, but you have some regrowing. This is something that can make our patients optimistic, less anxious, less frustrated. So it's nice to see. So I kind of like that they're showing this. And then I really like also that they show the partial response to this really fast responders. So within 8 weeks, 20% of patients achieved a SALT score of 50. So that to me is really, really impressive. That's 1 out of 5 by 8 weeks. You can see a SALT score. So I'll say with my own experience, I started prescribing LEQSELVI pretty quickly because I was kind of impressed by the data that was out there. So the very first patient that was able to get on the medication, I had been treating standard, just intralesional steroids, a little oral minoxidil, and I think some kind of topical anti-inflammatory medication, and had 0 regrowth. Within a month, which is shocking to me, within a month, the patient actually had regrowth in the patches. They had multifocal alopecia areata. So it wasn't someone that had totalis, it was multifocal, but I was really, really impressed with the rapidity of the regrowth. So that was interesting. So I saw that in one of my first patients that I prescribed with that. So I just love this slide because, again, you know, the endpoint of near complete regrowth by 24 weeks is one endpoint, but that's not realistic for our patients, right? We're seeing our patients sometimes monthly, sometimes every 3 months, depending on how we schedule. This is what we like to see, at least some hope, some regrowth. So this is really cool to see after 8 weeks. Okay, and again, like I was mentioning, when I have a patient that has eyelash loss, I'm going to be jumping to a JAK inhibitor a lot quicker because I typically was not able to achieve these kind of results with anything, you know, intralesional or topical. So you can see this patient almost looks like a different person. Baseline had no eyebrows, no eyelashes, and if you sweat, that can be really frustrating. It's just you look different, right? And by week 24, full eyelash, full eyebrow. So that is definitely treatment success in this patient. And then you can also see their scalp hair, right? They had very little scalp hair. I think, you know, you can imagine that patient's probably totalis or really maybe universalis at baseline and having a lot of regrowth on their scalp by week 24 as well. Okay, you got to talk about safety with LEQSELVI. So a total of over 1,700 patients were treated in all these trials. And again, that was over multiple different dosing schedules. Of the specific 8 milligram BID, it was over 800 patients that received the medication for 52 weeks. And then about 100 or more patients were exposed for greater than 3 years. So that represented almost 2,000 patient years of exposure. Okay, so adverse reactions in greater than 1% of patients. This is what you would expect to see amongst all the JAK inhibitor class. So with LEQSELVI specifically, headaches were common, like 12% of patients. Acne was seen. I will say the JAKne or acne that happens with JAK inhibitors, I don't see a ton of, but it does happen. And so we do treat it the same way we would treat acne. It is not less responsive because it is drug induced. You just treat it like you would your normal acne regimens. And then with the CPK increase, it's not something that we check at baseline, but I have with other JAK inhibitors had patients have increased CPK, and how they presented was new onset muscle aches and checked their CPK and it was elevated. And there's several schools of thought with this. You can just discontinue or pause the medication until the muscle aches calm down, recheck the CPK. If it's normal, go back on it. Some people just treat through and don't stop it. And I would say it depends on what's going on with the patient, right? If the patient has a full head of hair and they're very successful on the medication, pausing for a couple weeks or a month, that should not be a big deal. But if they have yet to see any improvement, any regrowth, it may not make sense to pause medication for muscle aches, right? So something to think about. Also, increased weight has been reported as well. I haven't personally seen that in my patient population, but it can happen. So if a patient says, hey, I gained a little weight, is it possible? Yes, it can happen. Herpes infections I have seen as well in patients. Let's go, as well as soft tissue infections. I've had one patient develop cellulitis. Mainly what I see in my patients are, and I don't know if it's the season, but prolonged upper respiratory tract infections, sinusitis, those kind of things. And what we do is we do pause the medication while they're on it, and then they'll restart once they feel better. And then I've also been counseling my patients, just because I think right now a lot of stuff is going around, just maybe wear a mask when they're in the airport, wear a mask when they're in public spaces, so that maybe they're less likely to catch whatever it is that's going around. I have had one patient on a different JAK inhibitor, but just to talk about, that is getting persistent UTIs. And because she really does need her medication to maintain her results, we do the same thing. We just pause, she treats her UTI, go back on, and then she's following with the urologist now actually to treat her current chronic UTI so we can stay on the medication. Okay, so adverse events of special interest. So you can see that malignancies have occurred with LEQSELVI. In this particular, up to 52 weeks, they did not note thromboses, but after the study was over, there were a couple patients that did have thrombotic events. So that's why on that box warning, it does say thrombotic events have occurred with LEQSELVI. It just wasn't within the trial period. Okay, and then with regards to infections, we kind of discussed that a little bit, but you know, I have had a patient as well that has developed shingles. Herpes zoster is something that we potentially should be screening for and considering initiating immunization prior to treatment or pausing treatment for a couple weeks so they can get their immunization. And then we'll go over laboratory abnormalities. They're listed here, but we'll talk about them in our screening. Okay, how does LEQSELVI work? This is not a funny story, but I'm just gonna tell you, my kids this weekend, you know how they say ATP at this point? These people, you know, they don't text normally. Everything's an abbreviation, etc. So I was trying to use their stuff, and they got me. So I was like ATP, and they're like, "Oh, you mean like the energy thing that we learned in biology?" I was like, "Are you guys being serious?" And they were schooling me about biology. I said, "Well, guess what? It is still relevant in our practice all these years later because I will be discussing a medication that blocks the ATP binding site." And that's how it works. So the kids will be fine. Apparently they're paying attention in their biology classes. And yes, it is still relevant, so however many years later. So that's how LEQSELVI works. It inhibits that JAK-STAT pathway by inhibiting the ATP binding site on the JAK protein so that STAT can't bind. And it well, let's get through this part. There we go. So it decreases that translocation into the nucleus, which would so basically the translocation into the nucleus increases gene transcription, which promotes cytokine release and the whole inflammatory pathway. And when we block it, it decreases that inflammatory pathway. LEQSELVI specifically binds JAK1 and JAK2 stronger than any other JAK. So it would be considered like a JAK1, JAK2 inhibitor. What happens, and you know, we all learned about this. When you look under histopathologic examination, you see that swarm of bees, the lymphocytes hugging the hair bulb, and that leads to follicular dystrophy and increased cycling. So you see shedding, and then you see those circular patches of hair loss. And so with you block that JAK pathway, it decreases all those signaling, the whole signaling pathway, so it decreases that inflammation. Okay, and then you get the healthy antigen followable. So I hope you guys like that story, because if your teens are saying ATP, now you got to be schooling them what ATP actually means. It's not at this point. Thank you. Okay, moving on. Okay, CYP2C9. This at first was a headache. I'm going to talk to you about how our office is doing it. And at this point, ATP, if I brought it full circle, it is not prohibitive to how we're getting it for the patients or how we're treating it. But you do have to screen for CYP2C9 in our patients, because if they're a poor metabolizer, it is contraindicated. And the reason is because you'll have higher drug levels in the system, and it could increase the risk for adverse events. So let me see here. I'm just going to talk about it now. Let's go back to this. So initially, when we were doing it, it was kind of a headache because we didn't have it streamlined. We didn't know initially that it has to go through LabCorp. And so initially it had to go through LabCorp. We had to have the right testing code on there, and our EMR system didn't have the right testing code. Now it can go to Quest and LabCorp depending on your community. So my community has a lot of Quest, it has a lot of LabCorp, it doesn't matter, but I know there are some communities that don't have a lot of LabCorp, and so you can do Quest. You just need the testing, you need the test code. Now it's so streamlined, I just say to my staff, okay, we're gonna start LEQSELVI. That's all I do, in and out, they know what to do. But I would say now it's so streamlined, it takes no extra steps for them. They already know it's queued up, LEQSELVI start, what to do, what to check. It's just something that if you have not initiated LEQSELVI yet, your staff is going to be breathing all hard. You're going to be breathing hard. It's going to be annoying. But once you get the hang of it, it's not even a second thought now. My staff just, it takes no extra steps. So it's something that your LEQSELVI rep can help you with if you want to initiate the medication, because, you know, like I said, it's not an issue right now. Okay, so again, LEQSELVI, it's one dose, 8 milligrams twice a day. Doesn't matter if they eat it with meals. If they miss a dose, they recommend skipping that dose instead of doubling up on it. And this is why. I hate this slide, to be honest. And the reason is, as you know, compliance is challenging. Although our patients are going to be very motivated, compliance is challenging. Look at the difference from when you take it 8 milligrams BID versus when you take both doses at the same time. It is far less effective when you just double up on the dose and take 16 milligrams daily, as opposed to 8 milligrams twice a day. And I was really disappointed with this slide because I was hoping that it would be very similar, so that for our patients that are, it's really challenging to take 2 milligrams or to take 2 tablets twice a day. You gotta just make sure your patients know this, that if they double up on the dose, the likelihood for an effective or an adequate response is gonna be much lower. Okay, how to get started with the medication. Okay, we talked about some of this already. You got to screen for tuberculosis, you got to screen for hepatitis, and then you do need to check CBC because, you know, kind of we skipped over this, but you can have lymphopenia, neutropenia, you can have liver enzyme abnormalities, and then you do need to screen for CYP2C9. I do check a lipid panel at baseline, and that's just because I prefer to know what they started with, and so I can kind of counsel them that, hey, your lipids are already a little elevated, you might want to watch what you're eating, etc., because this medication can bump the lipids some, and then you're going to continue to monitor the lipids over time. This is the test number with LabCorp, so it's 512269 with LabCorp. With Quest, it's going to be different. We prefer, if you're going to do the test, to send it to LabCorp because it will be covered by Sun Pharma. It's a little bit more challenging when you do it through Quest. So, you know, like I said, with us, it's very streamlined now, but first month it was very challenging. Now it's not a big deal. And then you guys have your local reps that can help, but there's also a support program. I have had really good success with getting this medication if insurance companies, I've seen this as well a lot now when I'm trying to get my patients LEQSELVI, they will tell me that they prefer other JAK inhibitors. So they'll have my patients fail other JAK inhibitors before I can start them on LEQSELVI, which is a little unfortunate, but I mean, at least they can get on a JAK inhibitor. So you guys may run into that some, but when they are getting LEQSELVI, I've had very good success. So LEQSELVI helps a lot. The support program, if it's not technically covered by insurance, they put them on these bridge programs. And so most of my patients have not had any issue as long as the insurance company doesn't say, hey, you got to start this other one first or fail this other one first. Okay, so why are we choosing LEQSELVI specifically over other JAK inhibitors? You know, like I mentioned, this is now the 3rd JAK inhibitor on market to treat severe alopecia areata. You know, this is a very nice thing. The reasons that you can consider it is it is fast. It did show statistical significance by 8 weeks. And like I said, in my experience, I had, you know, just the one patient that I was really surprised by, that they saw really rapid results after having failed everything else I was doing. So that was interesting. And, you know, 1 in 3 patients got near complete regrowth. And again, recall the baseline population. These are patients that are going to be our hardest patients to treat. So we can kind of counsel our patients, hey, you know, there's a chance for regrowth. It's about 1 in 3. for you specifically. And again, recall that this is monotherapy, and I rarely do monotherapy with my patients, but with monotherapy with LEQSELVI, these are the results we're seeing. Thank you. They're going to go to questions now.
Well, thank you so much, Meena. That was a forceful tour. I loved it. No question. And there's actually a bunch of questions that are popping up in the chat. So the first one is, just given your experience with this medication and the other JAK inhibitors, what characteristics of LEQSELVI distinguish it from the other JAK inhibitors in the market?
The main thing is, okay, the rapidity. So how quickly you could possibly see results. And I really like that they have that data for efficacy for partial responders, because that is more real world. That's what we're doing in our practices. You're not waiting for a full head of hair before you're like, yay, it's working. You're waiting to see some hair, right? Any new hair you're going to be excited about. So that's the difference for me. The one thing, like I said, that is a little challenging is that the patients really have to take it twice a day. So if they miss a dose, you know, and they do it frequent enough, are they not seeing efficacy because they're missing their doses, or is it really not effective? So that's the harder part. I think with the other JAK inhibitors, it being once a day is a little bit more, it's easier to be compliant.
Okay, very helpful. And next question is very similar, related to the patient's experience. So what factors have you found patients prioritize most when you're walking them through the various options in the JAK inhibitor market for AA?
Every patient is so different. So I have patients that I'm literally like, I really, really recommend you going on this medication, because I do not think we're being successful. What we're doing is not budging. I'm not getting success. And they're so hesitant with taking medications, especially ones that suppress the immune system. They want me to try everything else, PRP, you know, microneedling, whatever else I can be doing before they start that. And then there's the other side of it, where do everything possible to get my hair back, right? And so I think it depends on how well you're able to cover it and how much it's affecting you, right? So if they're multifocal, like I mentioned, and you know, we're having success in some areas, but other areas we're not preventing new spots from coming, and we're not getting complete regrowth in other areas, that's when I'll turn to a JAK inhibitor and say, hey, you know, I can't tell you when your next spot's going to come because they keep coming so quickly and we're not keeping up with them. This is what I recommend. Those patients are more likely to want to start a JAK inhibitor. If it's coming out really rapidly, I kind of just say, you know, I don't think there's much else that it's going to help, because, you know, we've all had experience before JAK inhibitors, right? We were doing anthralin, DPCP, just like torturing people with the irritants. We know that these are going to be the best medications that we have right now to help those patients with either severe alopecia areata or just like rapidly. And then, like I mentioned, the eyebrows and eyelashes, like, again, I was tormenting people with injections, topicals that just barely budged it. The JAK inhibitor class is going to be the best thing to get those to grow back.
Yeah, those are such good pearls for everybody. So I'm definitely taking some of those to practice. Pivoting a little bit, one question about timing, and I think this is so important because this helps us as we're educating, but per the clinical trials, per what you went over in the clinical trials, how early did patients with severe AA achieve a SALT score less than 20? And I think the sort of broader question here is, like, what's the timing we should be really talking with people about as they're starting the medication so that we can manage expectations?
Yeah, so I really like that partial response chart where it showed that by 8 weeks, 20% of those super hard to treat patients achieved the SALT score less than 20, or less than 50, excuse me. So 20% of those patients had 50% of their hair back. And so I really like that because it was really helpful for me now that I'm counseling our patients. But I don't give up on a JAK inhibitor until it's been at least a year. So I won't class switch and I won't change JAK inhibitors now that we have 3 until they've been on that medication for at least a year, because there's so much data out there now showing that there are some people that you will capture that are not complete responders, you know, by a year, that if you stay a little bit longer than a year, that you could capture those patients.
Yeah, it's such a great point. And the next question is another timing question, and I think it's something that you've touched on, but this question really gets to the root of it. Is, in your experience, to what extent does rapid onset, the rapidity that you've really hammered home in this lecture, how does that benefit patients in this experience with, this awful experience with severe alopecia areata?
Yeah, what I think helps the most is its impact on the psychosocial. So if you have even a little bit of regrowth within 2 months, that is going to change how you feel about yourself, about how your treatment is going, about your ultimate success for the medication. You know, all of us have patients that have been on these JAK inhibitors 8-9 months, very little regrowth, etc. That is so much harder to counsel patients. You have to just ask them to keep hanging there, keep on the medication. We're suppressing your immune system. We have little to no regrowth. It is so much better when you have even a little bit of regrowth very quickly, because it's so much easier for them, their mood to change, their anxiety improves, and their anticipation for their success is going to be better and more optimistic.
That's pretty compelling stuff there. I think you really hit on the logistical challenges of this medication, and this this next question is about the CYP2C9 testing. Yeah. So in using this test, can you provide some information on just how you walk through that process? You mentioned how now it's become more streamlined, but can you talk about the novelty of this medication? Someone's just asking for your experience using it.
Yeah, and also you can look at this as more personalized medicine, because it is looking at the patient's genetics, it's looking at how they're going to process the medication. So if it's something where a patient is challenging you on it, or yourself where you're like, oh, I don't feel like doing this, it is something that you can look at as more of a personalized medicine approach. Again, now it is super streamlined. It's part of my labs for my JAK inhibitor labs, and then if I'm choosing LEQSELVI, it's just clicked on. We actually have to write in that code because how our EMR is, there's no way to have it automatically populate, but the staff does it super quick, in and out. It's not a big deal. You're having the patient sign paperwork anyway. You have to fill out that tear off sheet anyhow. So it's just one extra step. I would really lean heavily on your reps to help you with that, because if you're in a community that does not have a lot of LabCorp, they're going to need to help you out, because we don't want our patients to have to pay an extra amount to get a screening for a metabolite, to start a new medication. So I will say the initial mindset was similar to Accutane. You know how we're like, dang, we got to do iPledge, we got to do this, all this just to get the medication. It's like, how motivated are you to put this patient on this medication? With Accutane, it's like, obviously we're very motivated, so we go through all that nonsense, the pregnancy test, etc., to get that medication. It's kind of that same mindset, like, dang, I really want this patient on this medication, so I'm gonna do this extra step. But like I said, now it's no extra thought to it.
That's awesome. And I love that concept of personalized medicine. I think that's something that we've heard a lot about for years and years and years, and we don't have a ton that actually, sort of in practice allows that. So the last question I have here is basically right out of your mouth, is using this screening test, which, we don't frequently use, but how have you been able to connect that screening test to a more personalized approach? And do you have any tips for how you communicate that to the patient or your staff or, anyone you're teaching?
So at first I gave a whole spiel about it. Now I don't say anything. It's just part of the baseline labs. If they should, unfortunately, I just had a patient today and we did everything we were supposed to do. And for some reason, LabCorp forgot or missed it. So the patient had to go back, and she was asking, do I really need this laboratory? I still need this lab. Why do I need it? And so I had to give the whole spiel that we do need to see if you genetically don't process the medication well. So it is more personalized medicine. And then let's note again that it's like 1 to 40% of the population actually are poor metabolizers. So the likelihood is just really low. It's just that's the only way to get the medication. That's the way it's FDA approved. So right now we do have to get that CYP2C9, but the likelihood of them being a poor metabolizer is extremely low. I would say half my patients are intermediate metabolizers, but that doesn't matter. It's not contraindicated in those patients.
Well, that's great. You've really laid a foundational groundwork for anyone who's going to start this medication, and certainly given us a ton of education about it. So thank you so much, and I'll hand it back to Roxanne.
Well, thank you so much, Dr. Butler and Dr. Singh, for a really excellent and insightful presentation on severe alopecia areata. And we'd like to thank again our supporters, Sun Pharma, for making this educational event possible. Now that this part of the presentation is completed, we'd like to invite you to join us next Tuesday for a joint approach to psoriatic disease management with Dr. April Armstrong and Dr. Gordon Lamb. And thank you all for joining us this evening. Good night, everybody. And again, Happy New Year.
New Year. Thank you.
Thank you.